Dr. Madhushree ACHARYA. She'll be talking about the comparison of 10,000 versus 20,000 cut rate of 27 gauge MIVS in treatment of PDR.
Good afternoon, everyone. I, Dr. Madhushree ACHARYA, postgraduate trainee from Second Sight South and Eye Center, West Bengal, will present my study on comparison of 10,000 versus 20,000 cut rate of 27 gauge minimally invasive vitrectomy surgery in the treatment of proliferative diabetic retinopathy. The objective of my study is to compare efficiency and safety of 10,000 and 20,000 cut rates of 27 gauge minimally invasive vitrectomy surgery in the treatment of fibroproliferative diabetic retinopathy. There is no financial interest, and the study is approved by Hospital Ethics Committee and is compliant with Helsinki Declaration. The study is a retrospective observational analysis done on data between January 2023 to July 2024 on 40 eyes of 38 patients with proliferative diabetic retinopathy. All surgeries been done by the same vitreoretinal surgeon. The inclusion criteria were adults with definite diagnosis of proliferative diabetic retinopathy requiring vitrectomy who followed up for at least 1 month of surgery. Any patients with history of previous vitreoretinal surgery in the same eye and those with pre-existing glaucoma and irregular follow-ups were excluded from the study. Outcome measures, efficiency parameters were vitrectomy time and membrane peeling time, and safety parameters were intraoperative and post-operative complications. The data analysis involved parameters like duration of disease, preoperative visual acuity, and intraocular pressure. And during surgery, vitrectomy time and membrane peeling time was noted, and post-surgery, base-corrected visual acuity, intraocular pressure, lens, and retina findings at 1 week and 1 month of follow-up were recorded. This is a distribution of vitrectomy time in the 10K and 20K cut rate groups. And this is the distribution of membrane peeling time in the 10K and 20K groups. Both the 10K and 20K groups showed mean vitrectomy time almost similar, that is approximately 9 minutes, while the membrane peeling time was shorter than in the 10K group. Coming to the safety profile, the overall complications were less in the 20K cut rate groups and with lesser incidence of iatrogenic breaks in the 20K cut rate group. A study on the evaluation of efficiency and safety of 27 gauge 20,000 cut rates per minute of vitreous cutter was done on patients with ERM in 2023 in Japan by Yuta Doi et al. But to the best of my knowledge, no studies in India has yet been done on comparison of 27 gauge 20,000 versus 10,000 cut rate vitrectomy in cases of proliferative diabetic retinopathy. From my study, vitrectomy time in both 10K and 20K groups is similar, while the membrane peeling time is shorter in the 20K group than in the 10K group, and 20K has a better safety profile compared to the 10K cut rate group. So in conclusion, the 20,000 cut rate per minute 27 gauge transconjunctival sutureless vitrectomy has better efficiency and safety profile than the 10,000 cut rate speed in proliferative diabetic retinopathy. Thank you.
See, when you talk about the efficiency of a cutter, you just talk about the time for vitrectomy and not the membrane peeling time. Right? You're talking about the functioning of the cutter. And when we talk about the vitrectomy time, basically, whenever we're talking about the efficiency of these cutters, you look at the core vitrectomy time and the shape vitrectomy time. That is one thing. Second, most of the studies, if you look into the literature, are usually retrospective studies, which are usually video-based when they calculate the time. That is again a very big drawback whenever these studies are being done and they try to look at the efficiency of the cutters, 10,000 versus 20,000 or 5,000 versus 10,000. Most of them are retrospective data. There's always some component of bias. You correctly showed that there is no difference in the cutting time, whether it was 20,000 or 10,000. So one point is that you should not include the membrane peeling time because the membrane peeling is not done by the cutter itself. That is you need a intravitreal forceps for that. And second, it is always better that you conduct a prospective study and you actually calculate the exact time which has been taken by the surgeon, and you have to define the limits of core vitrectomy, limits of peripheral vitrectomy. Sometimes the surgeon is biased, he might complete the core vitrectomy very early, or he might not do a very good peripheral shave, and then might feel that the 20,000 cut rate is better or is taking lesser time as compared to a 10,000 cut rate.
Okay, sir.
So I have a question. Do you know why is the time same between 10,000 cut and 20,000 cut?
So though like 20,000 should be having a shorter time due to efficient vitreous removal, but in our study, probably
No,
due
no,
to
why?
lesser
Why?
sample size and
No,
like
no, no.
the
Why is the 10,000 cut rate time and the 20,000 cut rate time almost the same?
uh, because in a few cases the time taken was more, and in a few cases the vitreous
So
removal
basically a 10,000 cut is a single cut and
is,
a
it is a single
20,000
cutter,
cut
it
is
is
a
a
bi
dual
cut,
blade
is a
cutter.
dual cut. So when the
Yes, sir.
dual cut is there, the flow rate is better in a 20,000 cut, and that is why it kind of adjusts to that time taken, and that is why the 20,000 cut rate, that is what the companies say, that is the model that you basically get the same amount of, you get the same efficiency as you get in a 10,000 cut. So if you do if you do the same thing with a large bore cutter, your vitreous removal will be much faster,
Yes,
right? Though safety gets compromised. So that is the reason why the time is same. And yes, I think membrane peeling time has nothing to do with the cut rate per se. You could say that probably the surgical time was less, but membrane peeling is generally not done. It is more about safety with the two cutters that you can probably compare.
Like the sphere of influence is reduced, so like the more it will cut into more smaller pieces, and that the duty cycle is like port is open all the time, so
Yes.
there will
So,
be flow.
so again, it comes to safety.
Yes,
That
sir.
you will make less iatrogenic breaks
Yes,
probably
sir.
if you're doing membrane removal with a cutter, or you're
Yes, sir.
dissecting the membrane with the cutter. But nobody can probably do 100% surgery with the cutter, membrane surgery. It has to be done bimanually or with scissor, forceps, something you will use. No? So if you
It's like 27 gauge. It's a multifunctional cutter.
no,
Like
I totally understand. We do.
okay.
We do, but we do complete with the cutter. But then if you have a FPP on the disc, you can't pull it with the cutter. Na? You would need a forceps or something.
And I think you're confusing because
Yeah.
you've written membrane peeling and not membrane dissection. I would agree that membrane dissection
Section
can
you
be
can-
done with the cutter. You can use a
Yes.
proportionate reflux, and then you
Yeah.
can use your cutter as a scissor, or you can use a momentary cutter mode. But doing a peeling, for peeling you would need a forceps.
Yes.
You can't peel anything using a cutter.
So when
Yes.
you talk about that thing that you're saying, the surface of influence, so what you talk about surface of influence is basically means that you can go very close to the membrane and you can cut, so you'll not lead to any iatrogenic break or something. So yes, when you study, if you study just membrane dissection with two cutters, probably 20K is better. But that does not mean that you complete the surgery with it, or you can complete all surgeries with it.
Okay. Thank you, sir.